Hi, I'm Dr. Neil Nandi. I'm the director of the Inflammatory Bowel Disease Center at Drexel University College of Medicine in Philadelphia, Pennsylvania. And I welcome you today as we discuss a little update on fecal microbiota transplantation, also known as FMT. Now, FMT is a procedure that's been done under other nuances for over 4,000 years, finding its first mention in ancient textbooks of medicine and Chinese medicine. And it's been done for millennia. Essentially, we believe that certain illnesses, for instance, recurrent Clostridium difficile infection, or C. diff, may be caused by an imbalance in gut flora, and that correction of this imbalance of good and bad bacteria and other organisms may be achievable by taking healthy stool, whole stool, from a human individual, a donor, and transplanting it inside the intestine of someone who has C. diff. So this is where it has gained much accolade in recent years. The first FMT was done in 1958, I believe, by Dr. Eisman, a surgeon, and when C. diff started to take its rise, almost on a global scale, starting in 2000, 2001, we started to see a growing need for performing fecal transplants for antibiotic refractory illness. So patients who weren't responding to C. diff antibiotics like metronidazole or vancomycin or fidaxomicin and other agents, they needed some type of alternative solution, and that was FMT. Just to give you an idea as to why I'm interested in FMT, we're finding more and more in 2018 that the gut microbiota seems to be the center of human health. We can influence our gut microbes with nutrition, we can influence them with antibiotics, for starters. And the idea has always been, can we manipulate the gut flora at all? In inflammatory bowel disease and Crohn's and ulcerative colitis, it's very important that we understand how gut microbiota influences the health and well-being of the IBD patient. A common reason, or shall I say not an uncommon reason, for failure to respond to some of the medicines that we provide our patients, that we call biologics for instance, is having a C. diff infection. When you have a C. diff infection, it can actually exacerbate the underlying inflammatory bowel disease. And so you may lose response to your medicines, and you won't regain response to the medicines until we effectively and definitively treat the C. diff. And that's why FMT has come into the foray, and why I'm invested in FMT to help our patients recover from their C. diff so they can regain biologic control or treatment control so their Crohn's and colitis can get better. Now, FMT is done a myriad of ways. We heavily screen the donors for infections. We make sure that they don't have any infections they can transmit in their stool, for instance, C. diff, and also multiple other infections in the blood, HIV, hepatitis C for starters. We're very thorough in these processes, and then we take that healthy stool, we blend it in saline, and oftentimes freeze it. And right now there are some public stool donor banks that are available that work on a nonprofit basis to provide this much needed treatment to our patients. It can be thawed on demand quickly and then infused in one of several different ways, either through a nasoenteric tube, a tube in the nose that sits in the stomach. There is some certain risks associated with that, such as aspiration if not done properly. Fecal enemas as well, which can be an easy delivery method, or colonoscopy, in which we actually do a full colonoscopy in a patient and implant the liquid stool into the colon. There's also the more evolving field of encapsulated stool, and several companies have been fighting the good fight in terms of research and finding what is the right amount of stool and delivery method into the small intestine and large intestine for encapsulated stool. So at this year's DDW 2018, there's many research updates. Some of the treatment research protocols that have been discussed was an early phase 1 trial done by a group of Norwegian medical institutes, in which they used FMT for first line to treat C. diff as opposed to an antibiotic. It's a small study. It did show a benefit in the FMT group versus the placebo group, but there was still a high recurrence rate associated with both groups. One thing to understand is we used to use metronidazole for mild C. diff per infectious disease guidelines, but that changed here in the year 2018, and clinicians understood that metronidazole could sometimes cause C. diff and wasn't as efficacious in preventing recurrent C. diff. So the new guidelines actually don't recommend metronidazole at all in the treatment of C. diff. We actually start with vancomycin. So again, that's an early study looking at using FMT first line instead of antibiotics as first line. Some of the other studies have actually looked at not only C. diff, but other illnesses such as ulcerative colitis. And we know from our wonderful Australian counterparts that did the FOCUS study, they presented some very interesting results on looking at short-chain fatty acid and bile acid metabolism. Again, the results are very preliminary, but we know that gut flora can influence how our gut bacteria change fiber into short-chain fatty acids. We need short-chain fatty acids to provide ourselves certain molecules for health. For instance, short-chain fatty acids include propionate, acetate, and butyrate. Butyrate is necessary for good colonocyte energy. It feeds the colonocytes, our colon cells, so that they have energy and can function properly. There's also some interesting studies outside of the lumen, outside of the intestine, for instance in cirrhosis. Cirrhotic patients, which is liver disease, totally separate, you would think, from the intestine. It turns out they have certain changes in their gut bacterial microbe composition and their short-chain fatty acid and bile acid composition. It turns out we often give those patients antibiotics to properly regulate those chemicals so that they don't absorb toxins from the gut and so they can be clear-minded. This study actually looked at taking fecal donor stool and implanting it into cirrhotics, and they actually saw a beneficial change in the composition of those molecules. So again, there's a lot of early studies that are being done into looking at both IBD and non-IBD, C. diff and non-C. diff indications for the application of FMT, but the science is still very early on. At least we know that we're finding more information about how we can use fecal transplant beneficially in our IBD world for our patients who are suffering from recurrent C. diff. Again, when you look at FMT for Crohn's, it does not seem to have any beneficial effect. And when you look at the data for FMT in ulcerative colitis, there are several promising studies that show a portion of our patients, a small portion of our patients may benefit, but they will likely require not only a first-time FMT, but maintenance FMTs, we believe. The ability to predict who those patients are, who will benefit from FMT in ulcerative colitis, that has yet to be fully elucidated. We don't have predictive markers to prognose such a good outcome. So we're making progress, slowly but surely, and I think that FMT is here to stay. I think the future of FMT is certainly going to be encapsulated stools, but moreover, finding what are the magic mixture of microbes, bacteria, yeast, and fungi that it takes to prevent C. diff or influence the primary disease of Crohn's or colitis itself, and identifying markers in the stool or even in the blood and the patient's composition that can predict who is going to respond and who won't. So I'm very excited, and I can't wait to see what the future will come. 1 year will pass, and in DDW 2019 we'll have a lot more information to share. Thank you.